Good afternoon, everyone, and thank you so much for joining us for today's conversations on opportunities for integrating youth behavioral health care across settings as we look ahead during the COVID-19 pandemic. My name is Jamie Young. I'm faculty lead for the Behavioral Health Portfolio at PolicyLab at Children's Hospital of Philadelphia, which is a research center within CHOP's Research Institute. I'm also the Director of Psychosocial Research in CHOP's Department of Child and Adolescent Psychiatry and Behavioral Sciences. As the COVID pandemic began to unfold, we knew that it would have a tremendous impact on children and families, not just their medical health, but also their mental health and well-being. We knew from prior research on H1N1, as well as early research coming out of China and Europe, that children would likely experience increases in mental health difficulties as a result of COVID-19, school closures, and financial difficulties associated with the pandemic. We recognize that this increase in mental health difficulties would unfold in the context of pre-existing challenges in access to and payment for behavioral health services for children and families. This led us at PolicyLab to write a policy review where we outlined 5 areas that are essential to ensure that all children and families receive the mental health services that they need following the COVID-19 pandemic and beyond. One of the areas that we focused on in this review was improving access by delivering mental health services in non-traditional locations, such as schools, primary care, and child care settings. Today, we're very excited to be joined by a terrific panel of speakers to focus more closely on the topic of integrating youth behavioral health care across settings. We're hoping that this conversation will engage a wider audience in this important discussion about the need to increase access to identification, prevention, and treatment for youth behavioral health. And we'll give folks a chance to hear from experts across the country about promising initiatives that can help advance our goal of increased access to high quality and equitable mental health care for diverse children and families. Before we get started, I just have a couple of reminders for those of you listening in to today's presentation. All lines will be muted and video will be disabled throughout the event. We're looking to a robust discussion following our presentations. So if you'd like to submit a question, you can do so at any time during the event using the Q&A feature located on the right side of the platform. My colleague, Shauna Dandridge, Policy and Strategy Manager at PolicyLab and co-lead for PolicyLab's Behavioral Health Portfolio, will be my co-moderator today. She and I will be monitoring the questions and will turn to them after the presentations. Before we dive in, I'd like to introduce our panel of speakers. First up, we have Dr. Tammy Benton. Dr. Benton is the Frederick Allen Professor of Psychiatry at the Perelman School of Medicine at the University of Pennsylvania. She's also the Psychiatrist-in-Chief and Chair of Psychiatry at CHOP, Executive Director of the Department of Child and Adolescent Psychiatry and Behavioral Sciences, and Chief of the Division of Child Psychiatry at the University of Pennsylvania. Next, we have Dr. Lee Beers, President-elect of the American Academy of Pediatrics and Professor of Pediatrics and Medical Director for Community Health and Advocacy at Children's National Hospital. Also with us today is Dr. Tamara Williams, clinical psychologist and Deputy Chief Clinical Officer for Children's Services at Community Behavioral Health, a division of the Philadelphia Department of Behavioral Health and Intellectual Disability Services. And lastly, we have Dr. Benjamin Miller, a clinical psychologist by training, who is the Chief Strategy Officer for Wellbeing Trust, a national foundation committed to advancing the mental, social, and spiritual health of the nation. I'm going to now turn it over to my colleague, Shauna Dandridge.
All right, great. Thanks, Jamie. To get us started, I'm going to hand it over to Dr. Benton. She's going to do a bit of level setting for us. Dr. Benton, can you talk a little bit about the mental health challenges that youth were facing pre-pandemic and the impact that the dual pandemic of COVID and racism have had on children and adolescents?
Yes, thank you, Shauna. And thank you for inviting me to participate in this important discussion. So as many of us know, prior to COVID, the prevalence of mental health conditions were pretty high, and they were actually starting to increase prior to COVID. There were increased rates of depression and anxiety among adolescents prior to the pandemic. We also know that about 9 million children and adolescents experience some kind of mental health condition or concern, including depression, anxiety, suicidal thoughts or behaviors. And that we also recognize that about half of those kids would have symptoms by the time they were 14, and that most of them would have symptoms, at least 2/3, by the time they reached 25 years of age. There were also long delays between symptom onset and treatment, with the longest lags being for anxiety disorders, which can be up to 15 to 20 years. And we also knew that for those who were actually identified, very few of them were receiving treatment, only about 30%. And that under treatment was much more common for minority youth than they were for majority youth. And of course, many factors contributed to that. Some of the challenges to access, in addition to limited numbers, were the numbers of professionals who opt out of payer networks for poor payment, and the fact that much of mental health treatment is private pay. Post-COVID, we experienced a significant increase in the demand for mental health services. So there's been a 35% increase in requests for outpatient care. That includes those children who were struggling prior to COVID and many kids who had no mental health risk prior to the COVID onset. Decreased access to in-person care has really further impacted access, even though we made the transition to tele. But the reality is that telehealth really works if you have access. And because of the digital divide, with lower income families having much reduced access to smartphones and much less access to broadband services or computer, tele provided some limited support for those families. These factors disproportionately impacted Black and Latinx youth. And another precipitating factor for increased distress for this population were disproportionate deaths due to COVID, impacting minority youth, with increases in grief, loss, and other stressors. And we know that the dual pandemics of COVID and racism further impacted minority youth with increased levels of distress, in addition to those already impacted by COVID. Pre-COVID, racial and ethnic minorities were less likely to receive mental health care, and when they received it, the quality was likely to be less than among majority populations. And then there's a lack of culturally competent care due to the lack of minority providers. So what we were seeing was increased anxiety, depression, traumatic symptoms requiring access. And then schools closing deprived a large number of kids, about 30%, of receiving any mental health services as many received them at school. On the bright side, and where there's opportunities, is that the pediatric services were still available during COVID, and they ramped up post-COVID. That provided opportunities for screening. And sick visits and increasingly well visits, urgent visits, emergency visits, which were decreased in frequency but still occurring, and then higher rates of inpatient medical hospitalization for Black and Latinx children due to COVID comorbidities really provided opportunities for identification of mental health conditions. Screening was actually available in all those settings, even though our preference would be that screening occur in primary care. It actually occurs in all the settings where kids are being treated for medical conditions. Screening all the children using validated instruments allow you to expand access and decrease disparities by identifying all kids at risk. So by screening, kids who experience trauma, anxiety, depression, suicidality, and psychological stress could be identified. And then we also know that that's increasingly important because most of the recent data suggests that younger and younger children are experiencing depressive and suicidal ideation and behaviors, and that there are fairly high rates of discrepancies between parent reports of suicidality and the children's reports of their own suicidal experiences, further emphasizing the benefits of screening. Pediatric integration really allowed us to have increased opportunities to reach kids who might be in distress. It allows you access to mental health assessment, risk assessment, care either on-site or through partnering with other services, increases the communication between pediatricians and mental health providers, linking mental health and physical health and integrating the care. There's also an opportunity, if we identify kids in the pediatric health setting, to support health promoting behaviors and well-being activities for youths and families. And then for those who have severe mental health needs, and we're learning that even for kids with conditions like schizophrenia, they're symptomatic as early as 9 to 10 years of age, establishing mental health clinician linkages early provide more intensive treatment options and greater health outcomes related to collaboration with their pediatric providers. These things are occurring, but there are many more opportunities for integration within pediatrics, within schools, with other child-serving groups. So those are my comments about our opportunities for improvements in mental health care delivery pre and post-COVID. And on that note, I'll return to Shauna.
Yeah. Thanks, Dr. Benton. I think, that was a really important perspective and I think such a great way to set the stage for today's discussion. I think, as you said, and as Jamie said before you, and I think as we hopefully use COVID to increase attention on behavioral health, it's going to be really important for us to be thinking about increasing access to care in places where young people present. So in primary care, as you spoke about, and in schools. So I think with that said, I'd love to turn it over to Dr. Beers. Dr. Beers, we know you've done a lot of work in integrating behavioral health into primary care, and would really love to explore your thoughts, including the potential for providing a continuum of services in primary care from prevention to intervention.
Yeah, no, great. Thank you. And again, likewise, thank you so much for having me today for this really important discussion. And Dr. Benton, thank you for laying the groundwork so nicely. I think, Dr. Benton mentioned the tremendous access issues that children and families have accessing primary care. And that really was a big piece of what led us to really focus in on primary care or mental health integration in primary care in Washington, D.C. I think very similar to a lot of the things Dr. Benton brought up, a couple of the things that really initially drove us to do this work were right, as pediatricians, we were just seeing kids in crisis who couldn't access services, and they were presenting to care, to their mental health care very late. And when they did, families were in crisis, and there was really a lack of community-based services for them or quality culturally competent community-based services for them to engage with. And so we really started to think about how could we think differently about how we were approaching community mental health care for kids in DC. And I think there were a number of reasons why we thought primary care was a good place to focus. And again, I think this is this isn't news. These aren't original ideas, but primary care really was a very natural setting for families. It's a place where families have regular and trusted interactions with their pediatricians and with the staff in their pediatric offices, and that's a really important thing for developing. It's a really important thing for developing continued mental health care. I think the other thing that was really important to us and that we really thought of as a benefit with primary care is that it does, as Dr. Benton mentioned, facilitate the early identification of mental health concerns much earlier than it would often present to specialty mental health care. And I think it also that there's a normalization that occurs when we talk about it in primary care, and I'll talk about that for a second, which I think does decrease the level of stigma involved with seeking mental health treatment. I think also, I think we all know there's a significant workforce shortage in terms of pediatric mental health care, and this helps us to address that by perhaps allowing some triaging of some of the more straightforward, less acute concerns to primary care to be co-managed, and with a transition of more serious or complex issues to specialty mental health care. And I'll talk a little bit about those things. So I think when we thought about how to approach it, we really applied a public health model to the work that we did, both in our planning and ultimate implementation with integrative mental health in primary care in DC. And that really ranged from sort of a more universal interventions to more targeted, and then to more intensive interventions. And I'll kind of walk through a little bit what we did for each of those. On the universal side, as Dr. Benton pointed out, universal screening for mental health concerns at essentially every well visit using a standardized validated tool. We now are at the point where we are screening at essentially every visit, including those very early visits for perinatal mood and anxiety disorders. I think also we really worked to try to create a welcoming environment for families to talk about mental health concerns. We put signage in the waiting rooms and in our exam rooms that this was a place that you could talk to your pediatrician. We did some specific training with our front desk staff and with our MA and nursing staff so that when they were handing out the screens, they knew how to talk about them with families and how to explain why we were asking the questions. And then we also sort of throughout the clinic in a variety of different places really work to provide information about community support resources. And I think we've been particularly good at doing this for our new moms and thinking about perinatal mental health support. The other thing that we've done, and this has not been in all of our clinics, though we're working hard on getting it across the city, is integrated the Healthy Steps model into some of our clinics, which is more of a primary prevention model integrating developmental supports into the pediatric primary care visit. So that was sort of a universal approach to the work that we were doing, and we worked hard to really support pediatricians along the way in implementing that, because I think that was one of the things that I knew as a practicing pediatrician and that we heard loud and clear along the way, which was none of this can just happen without support and resources, that it really does take time and support and attention to workflow issues and resource issues. And so we worked hard to be able to provide that to the pediatricians in DC. Sort of the next level of work that we did was around more targeted interventions, both within our clinics in pediatric primary care in the Children's National System, but also worked to support other clinics across the city with integrating psychologists and psychiatrists into primary care clinics. The workflow and volume is such that their role really is around providing consultation and perhaps brief interventions, 2-3 visits. But for psychiatrists, they really also focus on co-management with the pediatrician. But for kids who need more intensive concerns, we do refer them on. I'll talk about that in a second. We also developed and implemented, it's now 5 years going, a child psychiatry, one of the model child psychiatry access programs, modeled on MCPAP, which many of you are probably familiar with. And that is a phone consultation line with psychiatrists and psychologists and other mental health providers who can provide education and real-time support to pediatricians in their offices who are caring for kids with mental health concerns. I think the other targeted thing we did, which folks don't always immediately sort of group this in the integrated mental health interventions, but I do think it is that we have done clinic-wide efforts to screen for and address some of the social influences on health that families face. So resource insecurity, food insecurity, medical legal partnership. I think all of those things really do impact child and family mental health. And then in terms of the intensive supports, most of those supports really are in specialty mental health care. And so I think we see our role in primary care around connecting families to those services in the most effective and efficient way possible. A lot of that happens through our integrated psychology program, which is called Whole Bear Care, as well as through our child psychiatry access project, which is ours is called DC MAP, DC Mental Health Access in Pediatrics. And we have a care coordination team who works with our DC MAP program, and they maintain a very comprehensive resource guide and connect directly with families to identify where they live, what their insurance is, what their transportation is, and try to help them connect with the services that are most appropriate for their behavioral health condition, as well as most easily accessed to be able to receive their care. So that's sort of the spectrum of supports that we overview the spectrum of supports that we've provided. I think, just sort of summarizing, I feel like two of the most important pieces of this, and I mentioned this first piece already, which is just making sure that as you do the work, you make sure that your pediatricians and pediatric offices have adequate support to do the work. We're all addressing a whole list of things that are in the Bright Futures guidelines, and so making sure that we're thinking about how this all integrates into workflow and how what other additional supports are available to pediatricians, I think is really important. And I think the other really important piece to me, and I don't know that I fully realized how important this would be until I saw it in action, was just that all of these things really do normalize, both for the pediatricians and the care providers, but also for families, that normalizing the importance of addressing mental health concerns in pediatric primary care. And I think that sort of a tiered approach to the work has been really important in doing that. So with that, I'll pause. I know we have lots of others to hear from. I'll pass the baton back.
Shauna, you're on mute.
I think you're on mute.
Yeah, there we go. Thanks, Dr. Beers. I was just saying, you know, and Jamie, thank you for that. You know, I think the kinds of models that you were just talking about are so important for us to be thinking about when we think about sort of the legacy that's long separated mental and physical health care. And so, you know, we have to be really intentional if we're going to change those dynamics. And as I hear you talk about prevention, I also can't help but think about schools, as I think schools are really essential actors of any response at scale. And so with that, Dr. Williams, I'd love to turn to you now. We know community behavioral health has a really unique partnership with the local school district here in Philly. And we'd love to hear you tell us a bit more about that work and perhaps just globally, your take on the importance of delivering services in schools.
Sure. So schools really are uniquely positioned to offer a range of mental health prevention and intervention services because of their access to most children. So integrating mental health care into schools makes sense. And it's important because it increases the accessibility of care for vulnerable and marginalized populations of children, particularly those that Dr. Benton was speaking of earlier. And school systems like the School District of Philadelphia that incorporate a multi-tiered system of support framework offer an environment that is really conducive to models of integrated care because it allows for use of things such as staffed or graduated care and use of aggregate data to monitor population outcomes. And we're really fortunate in that CBH has had a long-standing partnership with the school district here in Philadelphia to provide integrated school-based mental health programs that focus on the full continuum of wellness, from prevention to early intervention to treatment to wellness maintenance. But the hallmarks of our integrated school-based mental health model are really, I would say, focused on 4 areas. One is using a combination of school-based mental health providers, mental health clinics that are co-located in schools, and then also formal relationships with mental health providers for specialty services for things such as crisis assessment and response. The second element is having a continuum of treatment interventions that vary depending upon the intensity of need. The third area that really is a hallmark of our model is integration of a behavioral health provider with the school team so that the provider really is woven into the fabric of the school culture. They participate in meetings with school leadership, they participate in school climate meetings, multidisciplinary teamings, and so on, as a way to coordinate all aspects of care. And then lastly, we also use data-informed approaches, not only at the individual level to determine whether a child needs more or less intensive interventions, but also at the population level to determine the overall impact of a program and how to focus resources. So I want to highlight 2 models of integrated school-based mental health care that we've implemented through our partnership with the school district. The first one is Regionalized Intensive Behavioral Health Services, or IBHS. And this is a team of psychologists, master's level clinicians, bachelor's level behavioral health techs who have registered behavior tech training. It also includes a family peer with lived experience parenting a child who's had behavioral health issues, and also a care coordinator who essentially performs case management functions. The team provides evidence-based treatment. They provide it in the home, in the school, as well as in other community settings that are needed. It also includes a teacher consultation model to help teachers feel better equipped to successfully manage behavior problems in the classroom. And they also assess social determinants of health and intervene by connecting families to resources needed as indicated by the assessment. Another element of this program is that our providers in our network are assigned to clusters of schools in regions of the city, and they offer access to behavioral health care in every public school. And I would say that what makes this a unique integrated model is that we use population level data to tier the intensity of interventions in each school. The second integrated school-based mental health program that I want to mention is called STEP. and that is the Support Team for Education Partnership. And this is a type of IBHS program that also serves K-12. It's a team of 4, so there are 2 licensed clinicians, a case manager, and also a family peer. And what's unique about this program is that these are also School District of Philadelphia employed staff, and they're providing Medicaid billable treatment services. So they coordinate care with school nurses, counselors, and any other providers who are involved in the student's care. And then they also focus on early intervention. So for example, students who are at risk for significant behavioral health problems or are already beginning to exhibit some problems. And then lastly, I'll mention that schools are broadly supported by our regional mobile crisis teams that we have here in Philadelphia when there is an acute psychiatric crisis. So those are just a few examples of the ways that we've partnered with the school district to integrate mental health treatment in school settings.
Thanks, Dr. Williams. Oh wait, let me make sure I'm not, I am not muted this time. Thanks, Dr. Williams. Again, just wonderful models, and it's really great to hear about all the work that we've got going here in Philadelphia and that you all are partnering in. Dr. Miller, I wonder if we could take a minute and turn to you. We've heard a lot about integrating services in primary care and in schools, and would like if you could take it a step further for us and share your thoughts on perhaps how we get different systems that interface with children and families to work together in a whole community approach.
Absolutely. Well, first, thanks again for having me here and for CHOP for putting this on. It's such an important and timely topic, as my colleagues have already said. So the hard thing about going last here is that I want to comment on what all of my colleagues have already said. So I'm going to be patient and stay focused and wait till we get to the Q&A because there's a lot to discuss. So I think to answer your question directly, and this sounds like such an overly simplistic answer, but I think it's the truth, is that it begins by actually having the families and the youth at the table in any discussion around any redesign. So it doesn't matter how broad you want to get on your integration formula. If we don't have the people who we're serving sitting at the table helping us think through what the solutions are, we're probably going to fail. In a report that we did recently with Academy Health, we called out that most policies for youth and families around mental health don't actually have youth and family involved in any of the creative process. So how are we supposed to meet people where they're at, where they show up, when we don't even talk to them about what they want? So any policy or program or payment mechanism that limits where a child or a family can get access to mental health is a policy or program or payment model that probably needs to be revisited. Because it's a story that we've heard countless times from our patients and their families, because these barriers stand in the way of all our attempts to integrate at no matter what level. But back to our youth and families just for a second. They're the experts that we need to really help us drive towards change. And what's interesting about policy, especially at a systems level, is that it's a complex set of equations. And you have to be at a really special place in your life, especially in health policy land, when you enjoy talking about this stuff, because it's hard and it's not easy. And if it were easy, then we would all be talking about the solutions. But it's the language that our communities use that we need to. And they know these things much better than we do. And they talk about it in different ways. Let's have them at the table for those discussions. Right now, when we look at surveys, and a lot of data has already been thrown out, so I won't say too much on that. But if we look at our youth and how COVID has impacted our youth and some of the ways that they are moving towards help me strategies and what can we do, 82% of kids, youth, specifically teens, are calling on our country to talk more openly about mental health. Like, let's listen to them. Let's hear what they think we should be talking about, how we can come to the place where we're actually designing those solutions that have them in mind. So I don't need to tell any of you the challenges of integrating in a culture that's inherently fragmented. I mean, we've all inherited decades of history and culture that has separated out the mind and the body. And we've done this structurally so many different ways. We're moving now into a place where socially we're talking about it more openly. But at a systems level, it's really hard to begin to embrace a new vision, a new mindset around integrating. So bringing mental health services, trainings, and interventions into a truly patient, family-friendly way has got to be our North Star. Each of us are fighting something that we've inherited, but it doesn't mean it has to be that way for everyone. And so I want to give you just a few ideas of things that I think we can do. But before I do, I just have to say this because I don't know if some of you saw these data that came out today. There were 2 data points that came out today that I think are just stunning for this dialogue. One was actually from the CDC, and it showed how there's been an increase in young adults between the ages of 18 and 24 who said they've considered suicide in the past month because of the pandemic. Fresh data out today. And with suicide rates continuing to rise, it's something that we have got to pay attention to and figure out more comprehensive solutions. And then there was another report that came out today by Milliman, which is an actuarial firm, that showed that half of mental health patients had very little spending on their treatment. In fact, it was less than $68 per year, if you can fathom that. And if you look at how they broke up the patient cohorts, there was another 25% of the patients who had very limited spending on mental health treatment, which was between $68 and $502 per year. So when you see how little we spend on patients who have an identified need, it actually it begs the question, why are we not doing more to go upstream, to screen earlier, to identify earlier, to do more things in the places that people are? So here's my big 3 things that we could do. First of all, I think that we need a new narrative for mental health. What do I mean by this? Well, quite unintentionally, and I'm sure we've continued to have this problem of conflating mental health with mental illness. And it's confused even the brightest among us. We use stats like 1 in 5 and use language that overlooks the power of mental health on our overall health and well-being. Let's begin to normalize mental health as something that is positive, as society has made it quite negative. And yes, there is a continuum, and yes, there is illness. I don't mean to minimize that. But from our coffee shops to Congress, we need to be really embracing this reality that mental health should not be something to shy away from. Let's teach each other that it's okay to talk about mental health. And let's embrace this new norm, a new narrative of how we describe mental health within our communities. Number 2, we've got to set a vision for excellence. And what do I mean by that? Well, I actually think that we need to define what excellence looks like for mental health in this country. We've got a lot of great programs, some really cool policies, and a lot of papers that have been published that show how we can deliver care a little bit differently. But what happens if we don't put all that together in a framework? I don't care how amazingly robust your p-value is for some intervention you did in the criminal justice setting, if that criminal justice setting is not connected to the education system, is not connected to the pediatric setting, and so on. We've got to think more about that interconnectivity between systems, and that requires a framework. So I don't want to spend too much time thinking about this, but our foundation has focused a lot on trying to come up with parameters around excellence. And it seems like a weird thing to say, but actually when you get out there and look at why we have not made a lot of progress towards mental health, it's because we've almost like programmatically painted ourselves into a corner. We've put programs and policies on top of programs and policies, and we've never really thought about deprescribing or getting rid of some of those old programs or old policies to make way for new and more robust supportive policy that can embrace a community integrated approach. Third, we've got to collectively move to action. And if right now isn't the most propitious moment to see profound action for mental health, I honestly don't know when is. And I hate to say this because I feel like the window is going to start to close relatively soon, but all of us are experiencing issues around mental health, both good and bad right now. So how do we recognize that our country is really embracing this notion of isolation and loneliness and uncertainty and fear and anxiety and depression? We've seen increased rates of depression and anxiety 25% compared to last year at the same time. Like, this is a moment. Let's take advantage of that. Let's get our collective communities to recognize what the problems are, know the issues, know who to talk to, which sometimes many of us don't, know what the solutions are that we can bring to those decision makers, and then truly all of us say in one fell swoop almost, this is what needs to happen for our communities. That is not one federal policy. That is not something that the state can just say, here's what we're going to do for our Medicaid program. This is actually solutions that come from communities, driven by communities, and connect dots in ways that we have yet to do as a nation. Thanks.
Thank you all so much. That was excellent. And I also hear you wanting to have an opportunity to respond to some of the other statements that people had. So this is going to be our opportunity now, really moving into Q&A and hopefully having a little bit more chance for dialogue. And so I think maybe as a starting point, several of you have talked about different ways of integrating. And just now we heard about some of the barriers to doing that, not having a common language, not really taking action. I'd like to think a little bit about I'm hoping you can each speak a little bit to some of the barriers and facilitators in your own work. And I'd also like to bring COVID-19 to this. As Dr. Williams was talking, I was very struck by your really compelling argument of what schools can do, and yet we're faced with a situation where many kids may not be in schools, and similarly access to some of these other settings may be different. So as you answer this question, thinking both about some of the lessons learned from your work to date, and also how you think these efforts may need to be different in light of this continued pandemic. Maybe we can start with you, Dr. Williams, and you can comment a little bit on that.
Sure. When you mentioned some of the challenges that COVID has brought about, I have also thought about some of the feedback from our providers who noted that being able to provide telehealth and having some of the restrictions waived at the state level around being able to provide telehealth has been a huge benefit. Outpatient programs have actually noted things like decreases in no-show rates. They're reporting things like parents find it much easier to participate in telehealth, even if they were a little bit hesitant at first. But for parents who have kids with behavioral difficulties and may struggle transporting them and getting them to an outpatient office, that telehealth has really been really positive for them. I think in terms of other things that facilitate integrated care across settings are models that eliminate barriers that vulnerable populations sometimes face, such as transportation and access. And then I would also say the use of evidence-based treatment is something else that facilitates integrated care. In terms of barriers, stigma, mistrust, misunderstanding about mental health treatment, that really sometimes leads parents to be reluctant to even acknowledge behavioral problems in the home environment, and to be reluctant to engage with mental health teams or to allow them to work in their home, which can be vital for transfer of skills. One of the lessons that we've learned is to incorporate family peers into our models who are adults with lived experience parenting a child with mental health problems, and we found that extremely helpful. And then I think I would be remiss if I didn't mention the barrier of workforce issues. Providers are sometimes hindered by their ability to attract and retain qualified staff, while we see increased requirements around well-supervised licensed clinicians and other frontline staff.
Oh, Jamie, you're on mute.
So good about not having my background noise, but now I'm going to keep it on. Other people have thoughts that they'd like to add about barriers or facilitators, or how you think this may look different either as an opportunity during COVID or as a challenge?
Yeah,
Go ahead, Tammy.
Oh, I wanted to comment on the utilization of telehealth for expanding access. So, most of us across the country pivoted from inpatient visits to telehealth in 2 weeks. And our telehealth utilization increased from 2% to 91% in 2 weeks. And many of us have been pushing for a long time. And of course, our no-show rates dropped significantly. But what we learned in our underserved areas was that a lot of children and families actually did not have access to the technology. And so we started to see skews in our own clinical population towards decreased numbers of ethnically diverse families and lower income families because they didn't have access. Some of the ways that we addressed our staffing issues was to utilize our teams differently. So that for our Atlantic City program, for example, we purchased iPads for families who didn't have them. And we utilized our drivers who would normally transport the kids to take the iPads to their homes. For some of the families, we were able to go to the food pantries because some of the kids got their meals during the day program. And so we had to really think about how to utilize resources differently. But in addition to that, one of the benefits, and we were looking for a silver lining in all of this, is that families who never made it in for family-based intervention for our day program, which is the most important modality of treatment in day treatment programs, they were all able to participate in care. And for the first time, you were able to see kids in their natural environments with their families, and you got a much better sense of why families weren't coming into treatment, and the tendency to pathologize the families in a sense for not being able to do the things that we thought they ought to be able to do in the outpatient setting really went away and strengthened the relationships between the provider teams and the families.
That's super helpful. Thank you. I know both of you wanted to say something. It looks like Dr. Beer's microphone is off still, so I'm going to let you go next, and then we'll have Dr. Miller go after you.
Okay, perfect. No, that's great. Yeah. I mean, and I certainly would echo what Dr. Bennett said. I think, when thinking about some of the barriers and facilitators, particularly in pediatrics and primary care, I think obviously, I mentioned this a little bit before, time are the things that come up when we talk to pediatricians. I really being able to carve out the time to do this well. And so I think it is something that we have to be mindful of. I think there are things that there are policy and regulatory and payment solutions for, so we should be thinking about those things for sure. And I think in terms of facilitators, one of the things a couple of the things that we really saw, one of the biggest facilitators was just having really committed champions in our primary care settings. Because when you have these committed champions, they really are willing to kind of work together with you as you work out the kinks. And that's been incredibly important. I also want to build on something that Dr. Miller mentioned about family and community voice. And I think that has also been another really nice and incredibly important facilitator. We've done some work with peer support, as well as engaging community leaders and families in program design. And I think that's been incredibly important, right? Because it's super easy to sit in our offices and design out what we think the right thing is going to be, or what we think is going to be most useful and impactful. But until we're really co-designing and co-creating with patients and families and communities, we really don't know. And I think that does involve more than just focus groups or kind of one-on-one interviews. It really does involve having community members and leaders and patients and families at the table with us every step of the way. And that's something we've had to learn over the years too. And I think there's a co-creation and co-design piece with our pediatricians and our frontline providers too, and our frontline mental health providers, because we're able to design the best solutions when we're doing it in concert with the folks who are most impacted from all sides.
So I'll give you 4 and build off of what my colleagues have said. I'll give you 4 here. I'm a policy guy, so I'm always thinking about policy here. And both a barrier and a facilitator right now is our United States Congress. Right now we put $425 million into mental health during this pandemic, which is 0.02% of the first $2 trillion that was put out there through stimulus. It's an embarrassment and something that I think all of us should be up in arms about. If they decide on what's going to go into the next package, we should, each of us, from our own vantage points, be screaming into whatever door we can that we need to put more money into mental health right now. It's a very easy way to help a lot of people. Number 2, which was already mentioned by Drs. Benson and Williams, is that we need to bring care to people. This is not a new concept. I mean, my grandfather was a family doc in rural East Tennessee, and he didn't have an office for like the first 20 years of him being primary care doc because he was always in the home. And so we need to revisit that for mental health. I don't like this notion that it's always about come to me. We need to disintegrate some of our integrated work and put it back out into the communities where people actually are. Number 3, workforce was mentioned by Dr. Williams. I couldn't agree more. We're never going to have enough. And so while we need to do everything we can on pipeline, let's get creative with who can do what, where, and for whom. I mean, I love this idea of contact tracers, right? We're putting millions of dollars through our public health departments into contact tracers. Let's train them up on basic mental health skills. Let's get them to ask 3 questions that they can ask around mental health and addiction. I mean, what's the cost of doing nothing? It could be a lot. And so I think it's an easy way for us to diverse and push a little bit more of those functions onto community, which interestingly enough would increase capacity downstream for our healthcare system. And then number 4, and this is a little bit blasphemous considering the topic here, but I think it's really important and it's a big barrier, is that we oftentimes have to have a diagnosis as diagnoses become a barrier for entry, especially with our kids. When we think about they have to have something that they are diagnosed as in order to get certain types of care, there's just something fundamentally wrong about that, especially right now with what we're about to witness with our kids going back to school. I don't want to wait for my child to be diagnosed with an anxiety disorder before I actually address the issues of anxiety. And there's a lot of professionals out there that unfortunately are not going to be able to move as quickly because of some of those antiquated payment methodologies that we've all inherited. So I'll stop there.
You know, can I comment on something that Lee mentioned? COVID was actually a facilitator for making our relationships with our pediatric primary care providers closer. And so, you know, because they were still seeing the kids, you know, the things that we needed to do to provide mental health treatment for kids who were in treatment, we really had to rely on our pediatric partners to take care of that. And it was amazing to me how quickly people took it on. And the result of that has been some of the pediatricians who initially did not feel that comfortable using medication management or some brief interventions for kids with anxiety and depression are much more comfortable managing those populations now. That was such a win. You know, it's the years of working on that. COVID facilitated that very quickly. And I think we need to maintain those models. We were more available to the pediatricians, which is really important because I learned that they will take on many things if they have access to expertise when they need it.
Jamie, do we want to jump into some Q&A questions? Thank you, all of you. This is a wonderful discussion and exactly what I think we hoped it would be when we pulled all of you incredibly smart and accomplished folks together. We're getting lots of questions on the Q&A. Jamie, unless you want to dive into one your own, I'll dive into some of what we're getting on the thread.
I think that would be great. I think it would be great based on what Ben just said related to the need for diagnosis to specifically focus on that question in the thread, because I think it's a very important issue and resonates really nicely with what was just discussed.
Absolutely. So I can read that question unless you want to, but someone wrote in and asked, for kids with Medicaid who have risk factors but not a diagnosis, have you had success, or have any of you had success in getting Medicaid, or know of places who have had success in getting Medicaid to pay for preventative behavioral health services? And if so, how?
Yeah, this is, you know, what Dr. Miller was just talking about. It's a significant barrier. I will say, and we know how important prevention is and early intervention. And having to have a diagnosis is limiting. I will say that at least for CBH, we benefit from being a division of DBH-IDS here in Philadelphia because they have funding to be able to support really good, effective prevention and early intervention services. And then sometimes we're also able to weave some prevention and early intervention work into some of the programs that are Medicaid billable. But I agree, it is a barrier.
Yeah, I guess one of the other questions that I would ask is that, you know, when we talk about prevention, you know, we really have not been able to find ways to consistently bill a problem as a preventive intervention. But I do think it's important to remember that symptoms of anxiety and depression are also disabling, even if you don't meet diagnostic criteria. And much of the early work that we do, we've actually been able to successfully bill for that by identifying a billing code that identifies some impairment in functioning related to the presence of those symptoms. And I think sometimes professionals get into this whole mindset that if you actually don't meet the diagnostic criteria, it's not a problem. You could be anxious enough that it's interfering with school, it's interfering with your social life, and those are all a focus of treatment. And so I think that there are ways to identify those risk factors and, you know, sub-threshold diagnosis as a focus of intervention for billing purposes. But I agree with Tamara. Once you recognize that someone is at risk and you can't identify symptoms, it's really hard to get any kind of reimbursement.
Yeah, no, I think that's right. And in many ways, actually, in pediatric primary care, we're best set up to be able to bill, to be able to get paid for their preventative work, just because we have restrictions on what we can bill, but they're different restrictions, I guess I would say. So, so I think for us, one thing we've had success with is being paid for doing the screening. That's it's not a lot, I'll be honest, but it's something, and it is important to be, every bit is important. The other piece that I think has a lot of promise is thinking about some of alternative payment models. I know we've been in conversations with 0 to 3 in particular around some potential ideas they have for alternative payment models around healthy steps. And so there's a number of different ways you could do it, and I think they're working through it with a number of different jurisdictions, including us, to see if we can kind of get to the finish line with that. That's another thing to think about, and I think as we're thinking about system redesign, as we're thinking about where we move forward as we come out of the pandemic, I agree, Dr. Miller, that we probably have a window where as a country we might be willing to think about things a little bit differently, and this is probably one of those things to think, whether it's enhanced payment for families who are participating in prevention models like Healthy Steps or other types of alternative payment models. I think it is an important thing to think about.
I will just double down on that and say absolutely, because I think that the rate limiter here for many of our innovations, especially around team-based care or community-based care, is the fee-for-service model. And Dr. Beers just said that really nicely. When we free practices up and providers up to have more flexibility with what they do with their time and for whom, and hold them accountable to outcomes, I mean, it really does change the entire dynamic. If you've experienced this in clinical care, you know what I'm talking about. It's like this weight that's lifted off your shoulders. You can actually do the things that you know you need to do without worrying about, is this going to get paid for? And I'm not implying that clinicians only do what gets paid for, but it just makes a different culture. So I think about the mom and the kid, or the dad and the kid, when they show up in a pediatric practice, and the parent is the one that needs treatment just as much as the adult. And being flexible enough in our payment methodologies as we pursue more dyadic type of payment methods to really support that family. I mean, it's funny because the more complex things get, the more simple they really are. And really, this comes back to the importance of just the individual in the context of the family and the family in the context of community, and creating some type of financial mechanism that just supports that.
Ben, one thing that happened, just briefly, to your comments and Lee's comments, it's a nice partnership between PolicyLab and mental health, so that the phone access service that Lee described exists in DC now exists in Pennsylvania, but that was very much related to the policy work that PolicyLab was engaged in to provide access. And so thinking of alternative payment models, that's all state funded. And so through that state funded mechanism, it provides access to Medicaid supported families for psychiatric and psychological consultation when they need it.
I agree. Ben mentioned doubling down. Is there such a thing as tripling down? Can I do that? Because I completely agree.
Very quadrupled. I'm in as well. Particularly if we can figure out a way to pay for prevention, which is the heart of all the work that I do. So I'm in.
Yeah. There's so many great questions coming in here. I'm trying to take a look at them and see, maybe we go back to this discussion. I know Dr. Benton and Dr. Williams, you were both talking about telehealth and the digital divide, and there's been a couple of questions about whether or not there's going to be greater engagement with the school district now that they're handing out Chromebooks, and whether or not that provides access for mental health. And then, a little later up, there was a comment along those same lines about, is that enough considering Wi-Fi and connectivity issues, which I think, Dr. Benton, you were sort of highlighting too. So I wonder if the two of you or anyone on the panel has thoughts about those questions.
Cameron, you go first.
Okay. The answer is yes, absolutely. Dr. Benton mentioned that telehealth, the pace at which we had to adapt to the implementation of telehealth is just phenomenal. And so things are changing so rapidly. Here in Philadelphia, there's been a lot of thoughtful consideration to the reopening plans, and we know that there will be kind of a online learning in the beginning and then some sort of reconsideration of hybrid. But we've been talking quite often with the school district here about how to incorporate telehealth, making sure that students have access to the technologies that are needed. I think there is a recognition that even though students may have Chromebooks, if they don't have internet access, then what's the point? And so we are actively talking about making available some community sites where students can go, where they can have access to the technologies that are needed to engage in learning, and then also serving as a place where the mental health professionals can provide treatment face-to-face if necessary.
And we are trying to expand our partnerships to be able to provide access to those services. So I think, one of the major things I've learned during COVID, which I knew before, but COVID reinforced it, is the importance of community partnerships. And, the academic institutions, we think we're understaffed, but we actually have a lot of resources, but we need to use them differently. And, to Ben's comments, there are many people that can do a lot of things, and we don't really optimize the utilization of those individuals. So, we have the capacity. We have a large number of clinicians at the Children's Hospital of Philadelphia. We need to be more connected with the community. We can support the telehealth services. But I've also learned that even sometimes when we have a connection with with the cell phone, the video connection is gone. And so we have to be flexible, and we have to be able to use our telephones to, connect with some individuals around those services. So, one of our major focuses around expanding access to care will be increased partnerships, contract relationships with agencies who need subspecialty services that we provide who don't have access, and that we're going to have to be flexible in how we provide them, including integrating things that we're not accustomed to using. So I noticed just yesterday, 2 new apps were released by children's hospitals that provided cognitive behavioral therapy activities between visits. So I think we're going to have to be much more open to trying things that we haven't utilized before.
Yeah, and Tammy, I think your point about the community relationships, again, I think we come back to this, is so important, and I think it's for us in COVID that we have relationships that we've been developing over a period of time, and that allowed us to really flip quickly and meet the needs in a different way. I think we have this great example. We have some work that happens in early childhood education centers with some of our early childhood partners as well as our community partners, but then when COVID happened, we were really recognizing the need for actually both teachers and parents in the center for some more preventative wellness supports. We were able to sort of bring those partnerships together with our psychology department, who provided the clinicians to run these wellness groups virtually. And that was a connection we were able to make within 2 weeks, right? That would never have, if we didn't have those existing relationships, wouldn't have been able to turn on a dime like that and have that seamless transition and trust that allowed it to happen. But it was such a wonderful way of everyone kind of coming together and readjusting to provide the supports that were needed.
Great, thank you. I'm seeing a lot of questions pop up in the Q&A around parents and teachers dealing with mental health and anxiety of children, and wondering about suggestions that anyone on the panel might have for helping kids deal with, fear, separation from school and classmates, socialization, all of those sort of things that kids are missing out on and parents and teachers are grappling with.
I think we all have something to say.
I feel like I should let the mental health providers answer first.
I will keep my comments brief because I think we've all thought about this a lot during COVID, and I always feel terrible asking parents to do yet one more thing. But so much of what happens with kids at home now during COVID really relies on the parents' ability to, first of all, control what you can and try to manage your own mental health and the mental health of your children. So making sure you get adequate sleep and exercise and all the things you are probably tired of working on over these many months are really essential things to do to maintain your own mental health. And then, we are trying really, really hard at CHOP to partner with parents and schools to educate the teachers and the parents about basic safety related to COVID, because parents and children are very anxious about what can happen to them if they're exposed. The other pieces are teaching parents and teachers to help young people manage their own anxiety, which starts with helping parents manage their own and giving them some control again over some of the things that they are able to control, which is their routines, their schedules, managing those things, and talking openly about the things they're concerned about with their kids, not frightening them, but conveying a sense that we'll get through this, we will manage this. This is difficult. I hear your concerns. I have them too. I'm lonely. Encouraging them to interact with their friends electronically and whatever their social bubbles would be has been helpful to me personally, to my team, to the teachers, and to the kids. So those are my broad comments.
One quickie here, because I know we're at time, but one of the most powerful interventions sometimes is just turning off the TV, turning down the radio, and just taking a moment to talk. Information overload, especially right now, is a lot. There's nothing on the news that's not about COVID, and that just adds to some of the anxiety that our kids feel. As a father with 2 children going back to school sometime in the near future, I can tell you that it's allowed us to actually have conversations and begin to normalize some of the feelings that these kids all are going to have heading into an uncertain time.
Absolutely. Yeah. We do have until 3:15, just as an FYI there, but I'm also seeing a couple questions come up on the Q&A around some of the apps that you mentioned, Dr. Benton, in terms of cognitive impairment therapies and others. Just so everybody knows, on this call, we will be sending out an FAQ or Q&A, sort of hard copy answering the questions that come in for any that don't get answered. Dr. Benton, I don't know if you remember the name of them or if you would need to dig, but if so, you could share it.
So I can't remember the name of so University of Cincinnati Children's just released an app. That's the one that I have actually spent the most time exploring. I can't remember the name of it. It was some cute, catchy name. But the Cincinnati Children's app for treating anxiety uses a cognitive behavioral therapy approach, a natural language processing, and a chat bot to lead people to the next steps. So it allows kids to practice. They just released it yesterday, and it can actually be purchased through the App Store. And I'm happy to share the name of it afterwards. I just can't remember now. But it was developed by Jeffrey Strawn, who does principally anxiety management for young kids, and Mike Sorter at Cincinnati Children's. And so they made a big announcement yesterday about the app. And so I've downloaded it, but I actually haven't tried it yet for myself. But it's for kids ages as young as 8, I believe. But it's a way to practice between sessions or visits. And then for kids who are just anxious about all the things that are happening now, it's a way to teach them sort of coping mechanisms for dealing with their anxiety. But I'm sure you can find it at their website.
And I'll also mention, go ahead.
Go ahead.
Did you find it?
One other thing that's very exciting that has just come out recently is a game-based therapy device for treatment of ADHD in kids. I think it's called Endeavor or Endeavor RX. So that was also recently approved by the FDA. But just, again, this theme of seeing more electronic virtual devices to assist with treatment, I think is something we're going to see more in.
I think the benefit of those kind of interventions is it allows the kids to have something they can control around managing themselves. And I think that's what's really nice. And then they can access it when they need it. And apparently the app at Cincinnati is only available for your phone. So you can't use it on your desktop. So you would carry it with you wherever you were going.
I think just in line with that, and then we'll transition. But I think one of the things that people have talked about today is just how far we've come. This idea that we went from 2% telehealth to 90% telehealth, that pediatricians are talking to psychiatrists in a new way, and the development of these apps. I think that it's been really amazing to watch and see that some intervention developers have taken their work and turned them into workbooks for families and kids. And really this idea that you can take some of those validated CBT approaches, and whether it's on an app or other thing, I think there really are tools out there for families to really help both manage your own anxiety and help with your children's anxiety and all of those things. And we will certainly plan on sharing those tools with you so that you have them in the follow-up. Before we end, I think it's been really great to talk today. And Lee, it's been so great to hear about some of your integrated work. And so as future president or president-elect of the American Academy of Pediatrics, I'd love to hear a little bit about your platform and how you're planning on continuing to amplify the importance of mental health.
And Jamie, before she speaks, can you mention that Dr. Beers was the one who introduced us to integrated care and helped us establish the model that we have for our whole system now. So thank you.
I don't need to say it because Tammy just did, but thank you. And then share how you're going to do that for everybody, because we love this idea that we're all recognizing the importance of behavior.
Thank you, Tammy. I remember I've been like thinking about that first visit the whole time. Wishing we could be in person again, I guess, but
exactly.
yes, exactly. No, well, thank you. I mean, and this, I mean, I think the past hour has been really just an incredible. It just sort of build up actually to what I'd love to share. I think. I mean, if anything, I mean, lots of things keep me up at night right now, of course. But if there's anything that really worries me, it is thinking about the impacts of on kids, the mental health impact of kids and families of both COVID-19 pandemic, but also the really this dual pandemic of systemic racism and the tremendous inequitable impacts we're seeing on our communities of color. And it just, I think the impacts of this trauma on children and families, I think we're going to be seeing for generations to come. I heard a talk not too long ago where someone was talking about family violence in the home and it increasing during COVID. And he said, I anticipate this will have negative impacts on community violence for at least 10 years. And so that's the thing that really worries me and keeps me up at night. And I also think, we've also seen, I saw a couple questions in the chat box about the back to school. This is what worries me about kids having virtual learning. There's clear safety concerns, and AP really advocates getting kids back to school as soon as possible, as safely when it can be done safely. But these are the things we worry about, right? Because we're not seeing kids as frequently, and it's harder to identify the concerns. And so it's going to be when we start to come out of this, I think we're going to be seeing lots of kids and families who are really hurting. And so I think that what I hope is that as we come out of this, we take this opportunity to say, you know what, our systems haven't worked the way they were supposed to for any child and for lots of kids. That it really hasn't worked for them. It's been very inequitable. And so let's think about how we can do this differently. Let's think about how we can build more equitable systems. And you talked about this a little bit, but let's think about how we can increase access to care for all kids and increase access to quality and culturally appropriate care for all kids. And so I think that's a tremendous opportunity for us as professionals and as advocates as we move forward. And so when I start to get down about the hard things that I think we have ahead, it's inspiring to think about what we can do moving forward. I think I would also say that I also worry quite a bit about, frankly, the mental health of our colleagues, right? My pediatrician colleagues, our mental health colleagues, because it's hard to be on the front lines of this. I think our families bear a greater brunt than some families. And so I do worry about that. And so I do think it's important for me over the next year and moving forward for us at the AP to be continuing to support our members, really focusing in on supporting their well-being, but also continuing to fight for those things that are causing stress, making sure that pediatricians and other medical professionals are getting access to the PPE that they need and the practice support they need and the financial support they need so that their practices are not struggling. And so I think really thinking about how we support our colleagues through all of this is really important as well. Within the AP, we tend to approach things through a lens of education, policy, and advocacy, and I think we'll do the same for this. Really focusing in on education about what the impacts are, how we can do things differently, how we can support others to do things differently. So I think that's one piece. We've had some really great ECHO projects, which are these sort of case-based learning sessions, learning collaboratives almost. We've had some great ones around COVID. We've had some great ones around mental health and COVID. We're looking into actually, and hopefully, knock on wood, I think this will happen, some ECHO projects around the impacts of racism on child health. And so lots of great opportunities for education there. In terms of policies, we've got a number of policy statements that are in the queue. We've also been rapidly producing guidance that's not official policy, but it's been needed quickly. So it's interim guidance around COVID-related things. We do have a policy statement in the pipeline. Folks may be interested around the impacts of adverse policing experiences on youth, and particularly youth of color, and that is that policy intent has been improved, and it's kind of working its way through writing and editing, and we are hopeful that it will be published sometime early in the new year. So that's working its way through. And then policy or the advocacy piece of it, which is just, Dr. Miller, to your point, continuing to fight for those things where we can really build our systems in a different way and support child and family health. I am continually saddened when I think about the school situation, right? And I think about the school reopening, that if we'd made different policy decisions, we actually could be getting our kids back to school now. And that we've made some policy decisions that have prioritized different things. And so that's why we're in the place we're in now. But I think we keep fighting to prioritize children and families in policies. So that's just a little bit for next year. But I'm really just forever just inspired and grateful by the number of both pediatricians but also other professionals who really are ready to jump into the fight together.
Sounds like a very relaxing year that you have ahead.
Yeah,
no giant national problems and things. Yeah, way to have just a small agenda. Excellent. Well, I want to be mindful of time, and I want to just have an opportunity to thank everybody who's joined us today, and really can't thank you enough, our panel of experts. It's been so excellent to hear from you, and it's just been a really terrific conversation. And so thank you so much. I hope that everyone who's listened has really taken something away in terms of the importance of continuing to emphasize access to care and the advocacy piece and policy piece as well. And I just want to remind everybody that a recording of the event will be posted on PolicyLab's website tomorrow. For those of you who don't know, that's policylab.chop.edu. And additionally, as we said, we will give some feedback on some of the questions that we weren't able to answer today. And I just want to thank everyone, and I hope you all have a lovely afternoon. So thank you so much.